Hi, I'm Dr. Robert Kaufmann, and it's time for us to go beyond the terminus. Today we're going to talk about increasing the efficiency of pulp extirpation, removal of the pulp. Here's the scenario. A canal seems blocked, and we work on it for a while. We then reach for a number 15 hand file and attempt to power through the obstruction, only to hear a pop, or find that number 15 file now goes a little too easily to the radiographic terminus. You remove it, and the canal fills with blood. When the case is finally filled, the filling appears to be at the terminus, but many times your canal filling goes straight when the root actually curves. We've made our own canal with a number 15 file and perforated the case at the blockage site. So how do we prevent this? One of the best ways that you can speed up conventional endodontic treatment is by removing as much of the pulp as possible prior to instrumentation of the canals. Leaving vital pulp in canals creates unnecessary obstruction and can result in canal blockage or inability to reach the working length. Let's examine why this happens and how we can avoid this problem. Some clinicians think that instrumentation of necrotic canals is the most challenging part of endo because we're dealing with an infected canal. When endodontists are asked whether they prefer to treat vital versus non-vital cases, in terms of pathology, non-vital cases are obviously more challenging due to the presence of bacteria in the canals. However, the necrotic pulp is more easily soluble by sodium hypochlorite because the pulp is already partly degenerated. I believe the endodontist Dr. Steve Buchanan once said that instrumentation of cases with the vital pulp can actually be more difficult to treat than necrotic cases. In vital cases, the tissues can be much tougher to remove. Continuing to place larger, straighter, stiffer instruments into the canal to force your way through the collagen only serves to compact this collagenous tissue into a nice tight ball and increase the risk of obstruction, ledging, and perforation. Since we know that the efficiency of the solvent action of sodium hypochlorite is time-dependent, it's important to leave it in contact with as much of the canal as possible for as long as possible. Leaving an intact vital pulp in the canal means trying to work around it or through it. And that means that solvents can't get to the deeper areas of the canal in the early stages. As my mentor, Dr. Herbert Schilder, used to say, the shaping facilitates the cleaning, and the cleaning facilitates the shaping. The easiest and most efficient way to remove an intact pulp is by using a barbed broach. Broaches are made of stainless steel, and in comparison to NiTi files, they're relatively inexpensive. They can save you a great deal of time and effort when attempting to clean and shape canals. Broaches are often used incorrectly and have gained a bit of a reputation as being a dangerous instrument prone to breakage. The barbed broach is nothing more than a wire instrument that's been notched in such a way that it resembles a piece of barbed wire. The barbed broach is used to entangle the pulp in the barbs and remove the pulp in one piece if possible. It's not to macerate or blenderize the pulp. One of the biggest mistakes I see is that clinicians do not have appropriately sized broaches that allow them to do this properly. Removal of a pulp is very similar to setting the hook on a trophy bass. The hook can't be too large or too small. Selection of the proper size broach is critical. Broaches come in sizes from XXX fine to extra coarse. Selection of a broach that's too small will result in the broach just piercing the pulp but not engaging it sufficiently to entangle itself and remove the pulp in its entirety. Selection of a broach that's too large risks engaging the barbs with the canal walls and potentially fracturing the instrument or breaking off the barbs and having them obstruct the canal. Selecting the correct size broach is the key. If you can't place a broach directly into your canal space, stop. Modify your access and your orifice shapes to allow for smooth, direct entry of the broach into the canal orifice. We need to insert the broach roughly 2/3 into the canal and then rotate it approximately 1 360-degree complete turn, entangling the pulp in such a way that the pulp can be removed in one piece. Broaches should never be inserted around corners or in fins. I must admit that a certain level of satisfaction occurs when the appropriate size broach is used and the entire pulp contents come out in one piece. I know that arrogance will now be able to be used in the deeper portions of the canal from the onset, and I'll also spend less time negotiating smaller hand files in my attempt to do a thorough job of reaching the terminus and cleaning and shaping the canals. Having a good selection of sizes ensures that you can do this with ease. Once you get in the habit of removing the pulp in this manner, your treatment will go much more quickly, efficiently, and easily. There also would be less chance of pulp debris being forced out of the apex during the instrumentation. And most importantly, there'll be far less chance of your instruments being obstructed and deflected or ledged during your attempts to instrument the case. Remember, when we do the right thing, we both get better, clinicians and patients. Thank you for joining me on this edition, and I hope to see you next time when we go beyond the terminus.